This week on the BackTable podcast.
My first one took about maybe a couple of hours until I took 2 or 3 sutures. Now it's 20 minutes, and 70% of my children go home on the same day, and 0 end up intubated unless obviously we're talking about a larger cleft or a deeper cleft. So I tell the parents, look, if I inject, you're going to come back again. And across the board, it's 50 to 60% response rate, 50% of them temporary, and the rest permanent. Whereas all the evidence is confirming somewhere between 75 to 85% good success with repairs.
Hello, everyone, and welcome to the BackTable ENT podcast, where we discuss all things ENT. We bring you the best and brightest in our field with the hope that you can take something from our show to your practice. My name is Gopi Shah, and I'm your host today. I'm a pediatric ENT, and I have an awesome guest. I have Dr. Hamdy El-Hakim. He is a pediatric otolaryngologist practicing at the University of Alberta in Canada. He's a Pediatric Otolaryngology Fellowship Director and the Clinical Research Director for the Department of Surgery. Dr. El-Hakim is also the lead physician of the Aerodigestive and Aspiration Program at the Stollery Children's Hospital. And he is here today to talk to us about laryngeal clefts in children. Welcome to the show, Hamdy. How are you?
I am fine. Thank you very much for having me, Gopi.
So as we get started, we usually let our guests tell us a little bit about themselves and their practice.
Well, I am best described as you have done. I am one of 5 pediatric otolaryngologists in the Stollery Children's Hospital, Edmonton, Canada. The best kept secret in the whole of the country, living-wise, practice-wise. I graduated in Egypt, and I trained there for a brief period of time, and then in the UK. Then I had the honor of going through fellowship training in Toronto Sick Children's Hospital. And then since 2002, I have landed in Edmonton, nascent and promising, and I am really at the last few years in my career, so I have the luxury of looking back and creating some narrative on how the stories unfolded and how I have served, and no regrets. I am a traveler and a discoverer, and it's all in search of a little bit more of a role and service to children, and a little bit of more of knowledge as well.
That's great. I love your curiosity and how much you enjoy exploring, even after 20 plus years of practice. I think that's wonderful. Today, my goal is to get as much insight from you and your experience about laryngeal clefts in children. I find these patients can be difficult to understand, diagnose. And, I kind of think of it, maybe this isn't the best comparison, but I think of it kind of like tongue tie. Just because it's there may not always cause anything. But sometimes if it's there, how does it play a role to the overall picture? So I'm really excited about this topic. First, let's just start with, how do you explain laryngeal cleft to families, and how do you classify them?
Well, I usually start by saying that the esophagus and the trachea, or the windpipe and the gullet, initially were one project, and they usually decide to split and go their own ways in terms of the role for swallowing and breathing. And the laryngeal cleft is essentially a low ramp in between the 2 entries, and it can get deeper and deeper, and the lesser fortunate are the ones who have a deeper one. But in terms of swallowing, I always like to explain to them that swallowing is a sequential domino-like process that basically starts in the mouth and ends up hopefully in the stomach safely. It has many factors that affect it, and we really need to take a holistic approach to the child. We need to make sure that breathing and swallowing are taken for granted and smooth as vision and hearing and a heartbeat. And in terms of the structural abnormality, I don't talk about the structural abnormality until I find one.
And how do you think of, so in terms of classification, if you're, teaching the residents or your fellow, how do you describe the classification?
I think the classic classification into 4 grades, I know that there are sub-classifications, but at the end of the day, the golden rule is never to depend on a flexible endoscopy. You have to do rigid endoscopy. You have to instrument. It takes really no skill at all to pick grades 2, 3, and 4. And lucky enough, they are pretty rare. So if somebody talks about vast experience, I think they'd be lucky or maybe unfortunate. But in terms of laryngeal cleft type 1, it always reminds me of the myth of Loch Ness Monster to some extent. Some people say that they have seen it for certain, and others say it was the effect of the Scottish whiskey.
So when patients come to you, how do they usually present? Like, what kind of symptoms will these patients have?
That's probably the very, very important starting point in even science and research, because it's a no-brainer usually to tell if there is an ear problem or a nose problem, because at the end of the day, it's symptom specific. The symptom leads you quite comfortably to the organ unless there is a referred sensation, which we all get taught in our basic years. But with swallowing and breathing, you have a common, let's call it cavity, which is the hypopharynx and the larynx. They are so intertwined anatomically and neurally, and you cannot always, especially in the classic age of presentation, tell which is affected and which is not. Plus, there is a little bit of a myth more, or let's call it culture and education specific, culture specific interpretation of symptoms of a child who's maybe choking, maybe having problems during mealtime, between pickiness, refusal, behavior difficulties, sensory problems. But you can get a child who has simple problems like coughing and watery eyes up to blue spells, limp episodes, or recurrent pneumonias. And even with the latter, you find that many people ascribe all of this to infections, run-of-the-mill. It's the period of infancy and toddlerhood where you expect a bit of immune development and an immune education, so people accept to some extent that there could be an RSV there or an adenovirus here, but it's the frequency. A healthy child should sit at mealtime and get funny photographs of, smudging everybody and everything, but it ends up with a long drama, a bit of kind of ritual in order to get this little one, fed adequately and the mealtime over.
It's interesting, I think of the younger, newborns and infants when I think of patients that might present with a blue spell, or they come into the ER with, having had to call the EMS because they turned blue at home and now they're in the ER. And now we're kind of getting into some of those questions about how they feed. Do you find that some of the symptoms differ by age? Like, what do you find in your toddlers or, even your older kids?
So this is a tricky one, because from research across the board, you'll find that the age of presentation is within the first probably 6 to 9 months. And that also gets adjusted when you extrapolate it to the date of surgery. The date of surgery or bronchoscopy is usually around year 1, which means essentially that there is time lag and delay. The older ones usually will have some form of a relationship to a lucky respirologist, and preschool asthma is a common tag for those children. And as a matter of fact, my first successful laryngeal cleft repair was a little girl who was 5 at the time, and she spent her first 5 years with monthly visits to the Stollery Emergency Department. And after we did that repair, and I must admit that I skeptically has performed it, the family reported a dramatic improvement, and that was my conversion.
That's amazing. Have you ever found a laryngeal cleft unidentified in like a older child, like 8 or 10, 6, early adolescent? Or is that just at this point now we know enough about it, we have enough studies, better understanding of swallow, so we tend to catch it earlier?
I think we're too early to say that we have established a knowledge base and a practice base across even in North America, which is a little bit more ahead, further ahead of the rest of the world in terms of aerodigestive practices. And the argument is always, you sometimes see laryngeal clefts without symptoms related to it. Okay. But that means that you have brought the child from the street and put them under anesthetic and did a bronchoscopy because they didn't have any symptoms. I think that's, to some extent that narrative is hard to kind of buy.
Do these kids have risk factors? Do these babies, have you found that it's more common in our, term babies, or, hey, this is actually more common in our preemies, or?
I like to draw the parallel with sensory hearing loss. We basically have a swath of patients who have sensory hearing loss and they do not have any other neurological problem. We have a good drill in terms of saying whether they were preemies, cardiac, had meningitis, etc. The same applies for the patients with swallowing problems. But again, we have to understand that swallowing problems are not as clearly classified and identified as sensory versus neural and even conductive hearing loss. So to lump and start to control and identify risk factors that are directly responsible, aside from famous midline abnormalities, like I yesterday, was in the OR looking after one patient, and the general surgeon was going to examine a TE fistula patient and operate on them, and they said, "Man, as long as you're here, why not perform an bronchoscopy?" And I had a look, which in many situations and in many centers, pediatric general surgeons will actually perform that examination. I located the TE fistula for him, but there was a type 1 cleft. Now, that is so subtle and outside the scope of their practice, no disrespect, because they are not laryngologists and they will miss many of those. In terms of other risk factors, I can't really tell that a laryngeal cleft in particular is my main focus. My focus is more into what we call swallowing problem and dysphagia. So I don't think I am that as obsessed by finding and detecting the laryngeal cleft as much as I am trying to explain why can't that child swallow.
And going back to symptoms, we think of swallowing problems, we think of, as you mentioned, coughing, choking, sort of watery eyes reflective of a choking episode. Do you ever have other symptoms like, something like throat clearing or, sleep disordered breathing or, any other symptoms that aren't necessarily quote swallowing, or, there's more to swallowing than choking as well. Like maybe they have to they make a funny face, or, what else do you think of in terms of symptoms?
That definitely is an interesting one because you've mentioned snoring. Half of my first 140 children snored. And I don't touch their tonsils and their adenoids. Granted, a good number of them, about 65% of this cohort, had an airway abnormality. They had either tracheal stenosis, believe it or not, or malacia or subglottic stenosis. But after I work also on the swallowing, quite often without an airway abnormality being corrected, the parents tell me the child has stopped snoring. The lesson is that sleep-disordered breathing can actually be mediated, not necessarily by an obstructive lesion, but by a compromise to respiratory reserve. In terms of the other symptoms like throat clearing, now that is a nebulous symptom. And it can be because of many reasons. Most people will also look at postnasal drip, try and identify another Loch Ness monster, which is gastroesophageal reflux disease, and that would lead you to really a cochlea, an endless cochlea of discussions, especially with gastroenterologists who are obviously the masters of the art and the benchmark creators for it. I'm careful a little bit about those. It usually is more in an older child, so the story will have been forgotten where was the trigger. But what I worry about, and maybe in context, is the constantly rattly child. This is a child who cannot clear probably saliva, and that needs a combination of inquiries. Part of them may relate to esophagitis, definitely, and I quite often see it in association with a child who have atypical croup, as a good number of these are associated with eosinophilic esophagitis or motility problems in the esophagus. And I must admit our center has not really invested enough in motility investigations, partly because the age group does not really lend itself to a motility investigation and a motility test. But there are centers in the United States who are far ahead in that respect.
So just to kind of recap, in terms of risk factors, we're always thinking of it as possible associated tracheoesophageal fistula, potentially other secondary airway abnormalities. You said half your cohort had tracheal stenosis, as well as subglottic stenosis. And then in terms of other GI comorbidities, we think of EOE plus minus GERD and esophageal motility disorders as well.
Correct. Again, I'm going to flip the argument again. And by that, I mean that how am I supposed to manage the child who has an oropharyngeal swallowing issue? Having taken care of oral problems, put them on the right track with the right professionals, speech and language pathologists, dietitians, and inquired to the best of my ability on esophageal problems. If I am dealing, and I know that I'm dealing primarily with an oropharyngeal problem, then a FEES or a modified barium swallow or a combination will identify for me the pattern of the swallowing problem. I know that we have the homing on whether it's penetration or aspiration, and for some purists it's the penetration or aspiration scale. But the brilliant idea that was proposed from, if memory serves me, from Seattle about the physiological cleft. There are children during FEES who can show premature spill only, who can show residues after a pharyngeal squeeze and swallow. There are others who may show penetration or aspiration from all borders of the larynx, be it an epiglottic undercoating or a spill over aryepiglottic folds, or actually the posterior penetration or aspiration, again, question mark, silent versus non-silent. I think that the augmentation procedure, being an injection or a repair, should be directed at those primarily who have a posterior penetration or aspiration at the discretion of the surgeon. And it depends on your aims, on your achievable aims. We don't always in a child with cerebral palsy or hypoxic ischemic encephalopathy achieve full oral feeds with surgery because it's too multifactorial. So it makes sense to have an appreciation that you want to advance the feed. You want to come close as possible to oral feeding, even if it's taste for some enjoyment, some degree of rehabilitation, a gradual one can actually flow. Generally speaking, I think that most children, you will reach a ceiling with them by around the age of 2. And then, if there is anything else that will come later, it really is a guess that is 50-50. You can't really tell which direction is it going to go through. But I generally like to tell the parents that one of the main objectives is to protect their lungs, particularly in the first 2 years of life, so that we don't have a respiratory cripple.
Just going back to physical exam, is there anything that you've noticed that some of these cleft babies, or when your consult, your initial evaluation is for feeding difficulties, are there, specific physical findings, or what do you go through on your physical exam usually?
So a general exam is a good idea, and I think pediatric otolaryngologists need to always understand that they are dealing with children who need some form of developmental assessment. And their communication, their general demeanor tells them a lot. A child who is not feeding properly is a child that is not generally very happy, not very relaxed. Subtle dysmorphic features are pretty important. You may be dealing with a syndromic child. You're not going to diagnose the syndrome quite often, but you can tell if the child has some dysmorphic features related to your area. And the other feature is testing for tone, because if the child has a low tone in the end, you can expect a few problems. The second issue is after you ensure that you have an oral cavity that is within average, that you have gone through the nose and you expected patency. Before you leave the nose, you should, I feel that whereas the young child, you cannot always tell a submucous cleft transorally, you can actually tell that the child has a submucous cleft with the telescope a lot better, because you're going to see the nasal septum, rather than inserting itself at right angle onto the floor of the nose, it will be flying in the breeze and creating a bit of an acute angle, and you will see that at the nasal side of the soft palate. Fees to me is the queen. So we're kind of, not biased towards the kings and males. The queen of all examinations. You really need to see whether you have an open and patent velopharynx or not, and competent one. Sometimes the first thing that you see is secretions inside the nose, saliva, as a matter of fact, foaming, not discharge. And certainly, if you see a little bit of infected secretions in the nose, especially in an infant, this is not a usual finding. This is telling you that there might be some nasopharyngeal escape. And then when you look at the larynx, in an infant in particular, we all know that the larynx is a bit high. And the epiglottis usually gives you the high five. The high five, definitely before you even notice the base of tongue, you should see the epiglottis. If you see the epiglottis being hugged by the tongue base, and the tongue base is slightly higher, your odds of finding an anterior larynx is pretty high. And that particular risk factor, if you ask about risk factors, that is almost, in my opinion, a slam dunk. You're going to find a problem that needs a bit of rehabilitation there. The way the larynx and the hypopharynx handles salivary secretions is very important. And there are no benchmark classifications. There is one from the adult world, purely subjective as any other endoscopy. And then you need to draw on your experience in laryngology. So the Pfizer needs to be really an accomplished laryngologist. Child is not always incredibly happy, although we have advanced. Initially, we never tried with toddlers, but now we do it with them, and we have our own ways of entertaining them and convincing them diplomatically that we're doing well, and we mean well. So you determine whether you have malacia or not. You determine whether you have a movement disorder or not, and I use that word in particular rather than talking about paralysis. And then you start your show with the feet, which the child really needs to play ball with it. And some of them definitely will say, not today, don't try. And I do not forget to auscultate. And that's something that we forget as an art. And it tells us a few things. Certainly, it tells us whether the lower airway is affected or not. It tells us whether it's purely upper airway. Not purely, of course, but it definitely does help. And a good proportion of my patients also were dysphonic. And that's the other thing. That the parents will quite often tell you, upon asking, the child's voice is weak.
Do you ever notice, you said you look at mobility, in terms of vocal cord mobility, do you ever see sluggishness or mobility or dysfunction in mobility?
There is a good number, and it's a research and a practice interest of mine. I think, in short, people have not documented very well non-paralytic mobility disorders like arytenoid dislocations and fixations. You more often will encounter fixations with stenotic lesions, acquired stenotic lesions, and you will need definitely to examine them under anesthesia. And by extension, I feel that the literature skips that step. And in my controversial publication about the natural history of bilateral idiopathic paralysis, when I did my systematic review, I said all but one skipped an examination under anesthesia. If you go through your board exam or your fellowship exam and you see a flexible scope view and the larynx is not moving and you say the larynx is paralyzed, the examiner is bound to give you a note for your answer. But in the world of research, they say Dr. El-Hakim said that it was paralyzed, so it's paralyzed. And that really doesn't work because that distorts our information about the natural history and epidemiology. The next thing is that arytenoid dislocations are often in cardiac patients, particularly in children who have an anterior larynx. And sometimes when you go under the wraps and you are reintubating a child whom you have done cricoid split and grafts, and people are under the tent of the drapes, and they could quite easily knock off a small larynx, going in and intubating the child who basically has an open airway and an open and a split larynx. The last one is that, then that's my up-and-coming work, is on laryngeal dyskinesia. Some people conflate the diagnosis of paralysis and palsy and dyskinesia. And there are very few large series that include the word dyskinesia. And in my series, the word dyskinesia, based on EMG and based on physical and clinical exam, is documented as many times as bilateral paralysis, which changes the natural history. And these are quite often associated with swallowing abnormalities as well.
That's very interesting. Just going back to, you said FEAS is your queen. Is there a role for the video swallow or OPMS in your practice, or when do you consider getting the video swallow in addition to or in place of the fees?
The modified barium swallow is the benchmark whether we like it or not. Historically, this is the beginning. This is where authorities relate to. Many argue that this is a natural position of the child to feed, although it depends on the culture. So, for example, our indigenous population don't usually feed their children, or so I am told by the speech and language pathologists, in a high chair. And that can sometimes create a little bit of an unnatural situation for them. The second thing is that the modified barium swallow, as we all know, is a lateral view X-ray. So it does not show me a panoramic view of the larynx. The examiner and the radiologist will go through a series or multiple sequences, and they will pick the relevant views that have even a proof of normality or abnormality. There is the degree of radiation. Do I always get a successful functional endoscopic evaluation of swallowing? Certainly not. But with experience, we basically do close to 90 a year, each arm of this clinic. So we probably go well over 150 a year. So we have very good experience with it. It's attractive always in infants where the risk of carcinogenesis from radiation is pretty high. To start with the fees, you have information that is unachievable, at least in terms of the laryngeal mobility, its structure, its handling of secretions. The subtlety of handling secretions does not appear on the modified barium swallow as clearly as the fees. And we combine them. I don't really see it as a competition between the two modalities in any way. So it depends on the child, and it depends also on the baseline of the child. So if I take a decision of management based on a modified barium swallow, it's ideal if I repeat the same study after treatment. So these are really, generally speaking, the odds and the factors. Again, practices vary. Sometimes the preference of the parents vary. Parents are sometimes quite averse to the risks of radiation, and in the same instance, some others might not imagine how the fees could go. Although in my own experience, they basically sit and say, "Is that it?" I say, "Yeah, that's it."
So let's say we have, the 1-year-old that you're seeing. The child is rattly, she's gurgly. Let's say she had a history of a pneumonia at 5 months and has had, an ED visit at 2 months and then another ED visit at 8 months. Both of the ED visits for trouble breathing. And let's say you evaluate her and you do the fees, and, you might see a little premature spillage. At that point, do you start thinking, okay, when do you start planning for a DLB? And when your suspicion is high for a laryngeal cleft, do you talk to the family about that diagnosis, or do you wait for your DLB and see what your findings are? Kind of tell me about what the next steps would be for that patient.
Of course, I have to talk a little bit about the tiers of our assessment, because in most United States aerodigestive programs, it's a one complete examination by all the relevant specialists: GI, respirology, ENT, and speech and language pathology, and maybe others. We have 2 tiers because the vast majority of our children can actually be assessed comprehensively and managed between the otolaryngologist and the speech and language pathologist. So that's what we call our aspiration clinic. The second tier that may be required are the children who may have established lung diagnosis, for lack of a better word, or high suspicion of GI, complex patients in particular, those who have tracheostomies or are graduates from our tracheostomy clinic after establishing a good airway and a patent one and getting decannulated. Also, the patients from our tracheal program, in which I and the cardiovascular surgeon, Dr. Mohammed El-Hakim, have established in Edmonton. We manage in it the tracheal stenosis and related lesions. And in addition to that, the tracheoesophageal fistula patients. So we find that the monthly clinics of aerodigestive program are a bit more complicated patients, those who stumble from the aspiration clinic, or we feel ab initio by one of the members that the rest of them really should see it. In terms of our approach, it's probably classical. The clinical evaluation takes place at the speech and language pathology office, partly over the phone, partly in person. Rule of thumb for everybody, especially that those clinics are going to be always in a tertiary quaternary level. These are high-risk patients. You don't go in and send them an invite in order to come and visit you. They have symptoms or they have conditions that put the patient at risk. So clinical examination on its own is never enough. And that is an established benchmark of practice. And then we meet together in the aspiration clinic, no less than half an hour consultation, going through a standard set of questions and elimination of risk factors, inquiry about cardiac, respiratory, developmental, the rest of it. If we can get away after the fees by introducing a thickened diet, a modified diet, or some advice in terms of pacing and so forth, then that's good. We're going to reevaluate back again and see how does the child do. And that includes preliminary assessment and treatment sometimes of gastroesophageal reflux disease, bearing in mind that our glorious PPIs are now uncovering their ugly face in terms of side effects and so forth. The next step, I never really stage endoscopy and surgery. If I am failing with conservative or medical treatment, I will go and scope. I will never delay an endoscopy if the child has already dangerous symptoms like blue spells or apparent life-threatening episodes, or they failed within a short period of time if you were getting recurrent pneumonias and chest infections, or if they have an alternate route of feeding. Because one of the main objectives of any clinic or any program is to reduce and shorten as much as possible the period of non-oral feeding. Then I will go and tell the parents, depending on my findings, look, I've seen a mobility disorder. I'll see what I can do on the day of reasons, or I am suspecting that we have a posterior problem over here and I need to augment that area. I give them an overall view of the two main methods, whether it's a surgical repair or an injection. And I quite often will say there is a possibility of a GI specialist coming in the same time. And I quite often will take bronchoalveolar lavage as well in the same time. The jury are out in terms of the utility of the yield, whether you really depend on the identification of lipid-laden macrophages or not, whether you have a child who have oropharyngeal flora and way more than contamination in the lower airway. Trust me, the interpretation of this in the literature and experience is at least heterogeneous. So at the end of the day, I try and limit trips. I try and combine the endoscopic examination. I will do the airway examination to start with first, with agreement with the respirologist. In follow-ups, should the child have adequate examination and treatment by otolaryngology, and the remainder is a substantial plan for respirology, then they go and do subsequent lower airway examination. That, in my opinion, is more economical in terms of time, effort, and grouping of people together.
Yeah, every once in a while, I'll have a young newborn that's admitted within the first 3 to 6 weeks of life with, a blue spell. They get admitted. It's noted that they're having feeding difficulties. They see speech and have a feeding evaluation, and there's concern for aspiration. And we get consulted on the inpatient side in the NICU usually. And if we're not making progress, we don't have a good feeding plan, then we end up doing these DLBs or direct laryngoscopy, the evaluation while they're inpatient. At that time, do you usually also go ahead and talk to your GI colleagues if you are planning a DLB? It makes sense to me on the outpatient side, with a structured aspiration and feeding clinic, because that partnership and that system is set up for it. But every once in a while, the consult is outside of that system.
No, it makes sense. Most definitely. Particularly the age range that you're talking about, Gopi, is tricky because you don't have enough history to kind of tell whether the child has esophageal problems. There are some that will do. I remember, a CMV infected child, congenital CMV child, who basically had raging reflux, and that was one of the very few slam dunk situations where a fundo has made a world of difference without any problem. And that is the other factor that you occasionally may see on a VFSS. You don't see an oropharyngeal abnormality, meaning aspiration from above, but you see an aspiration from below with regurgitation of the bolus and entry in the airway. Again, that age group is really very, very tricky, and it's not impossible, obviously, to find clefts particularly, but a stridorous patient in the first few weeks of life is usually a mobility disorder, in my own opinion, until proven otherwise, unless you're lucky enough to find your annual 2 or 3 tracheal stenosis patients. And again, I'm very careful when I talk about laryngomalacia. I haven't uttered laryngomalacia many times here because I think that laryngomalacia is an entity that needs further epidemiological and clinical description. I dished out 90 videos for 4 surgeons that are experienced, fellowship trained, and I told them classify the laryngomalacia that you see. And I inserted 20 videos that were totally normal. And the agreement was abysmal. And it just shows us that, and it's not really, it's no disrespect. As a matter of fact, what we're talking about here in most of the topic is endoscopic evaluation. And endoscopic evaluation is subject to inter-rater and inter-observer variability, where a lot of science has proven that even biological factors will impede the agreement between the best of people. And that's one of our main barriers talking about, swallowing over here.
Yeah, it's true. The inter-rater variability on laryngoscopies. I mean, something as we think as simple as vocal cord immobility can be really difficult, and you can record it and show it to 3 different people, especially if it's concerned for bilateral, and you will get 3 different answers oftentimes. And it can be really tricky. Okay, so let's say we are in the operating room. How do you do your DLBs? Do you have tricks for your setup and for suspension? And how do you like to evaluate for a laryngeal cleft?
In terms of the tricks, I definitely ask in most situations for a flexible endoscopy, unless I have done a nice, well-documented FEES and I do not have any suspicion about a laryngeal mobility problem. It's pretty important in children who snore. The suspension itself, I think it's a classic one, but I insist to sometimes even the miffing of my fellow anesthetist on having the first look and putting the local myself, because I want to see how much secretions are there. Because after a child been fasting for 6 hours, you should go and see nice glistening mucosa, but no pooling of secretions there. I generally will suspend them. The most difficult suspension are those who are younger than 6 weeks. Those guys will need your Parsons, and the Parsons is notoriously wobbly. So I use a set of tricks with tape here and there, and that stabilizes the patient nicely for me so that I can look and be sure that I'm a happy man and I have a nice panoramic view. The tape essentially is to create a cricoid pressure, and on one side, usually the opposite side to the anesthetic circuit, in order to stop the traction that comes from it, and another one on the suspension mechanism, which is usually twinned with the Parsons. That's, the little disc rather than the flared one. So these are the secrets of my grandfather. And the other one that is that should not be escaped is the poor view of the larynx. So if you really have less than a grade 1, always document it, because that might explain something for you. Might explain why your child might have a problem. 50% of my series of anterior larynx, very different from a Robin. That is one kettle of fish, and that's another beast altogether. That may prevent you from doing a laryngeal cleft repair. And another trick about it may appear in the awake child as a type 1 laryngomalacia with posterior prolapse, and once you sedate them, you look with the flexible scope, you're not going to see it. And when you suspend them, you certainly don't see the features of laryngomalacia. And if you insist on doing a supraglottoplasty, this will be heralding 2 or 3 days of tough time for you and for the baby, because they don't heal very well and they are very unforgiving. Generally speaking, the remainder is dependent on our right-angled probe. But if you go to the literature, which I have looked at, there are many clever people and who have published in how to examine the child, and maybe even Dr. Richard Smith has created the special instrument for measuring the laryngeal cleft. The variation of 3 millimeters between one child and another across a huge age range does not lend itself to measurements that can actually be reproducible, in my opinion. It's incredibly clever, no doubt about that, but I think some of my fellows and my residents looked at me and said, where is this cleft that Hamdy is seeing? That guy is seeing, is imagining things. So that's why I tend more to document what I could see. But if I have the posterior aspiration in the clinic during the FEES, then I go ahead with a repair or another augmentation procedure.
Just going back, you said you always have a flex scope, especially for your snorers. Do you dice all these babies then?
Yeah. Yes, and as usual, it's a fixed drill, no inhalational anesthesia, total intravenous agents, and I think again, my fellow anesthetists here at the Stollery, at some point thought that this is going to be another era of 30 years of difficulty with this madman, but now they're quite adept at it, and it takes less than 5 minutes.
Is their vocal cord spreader ever helpful to you when you're looking for these?
The vocal cord
spreader, does that ever help you widen the gap and help you check depth? I mean, I'll be honest, I do not use that routinely in my practice to check for a cleft, but sometimes I'm curious, like, am I not evaluating enough? Is there any benefit to that? But most of the time I don't use it.
I don't think so. I don't use it for the evaluation. This is really just mainly for access of lesions and clefts below the level of the cord. And depending on the age of the child, the spreader can actually be a space-occupying lesion in its own right and a hindrance to bimanual kind of work.
So usually these babies, you said, I try to minimize taking them to the OR on multiple trips. So I would imagine that if your suspicion is high enough, especially based on your FEAS evaluation, the history, your assessment in clinic, you've prepared the family that if you do detect a laryngeal cleft, that you'll go ahead and repair or augment it at that setting. Yes. Okay. That's and correct. So how do you decide, when you're going to do a formal repair or when you're going to do an augmentation? And for augmentation, I think, I always think of the gel injection augmentation. Is that what you use as well?
I have started certainly with the injections. And the real reasons is that historically we were all skeptical about the role of the laryngeal cleft type 1 or the deep interarytenoid notch in the whole process. So material has evolved. I used once gel foam, and I discovered soon that it's close to a waste of time because it oozes out and it doesn't really get retained in the tissue for too long. And then I started to use hyaluronic acid, essentially availability. And this was available because the urologists use it, and it's smooth, it's quick, it's present, its history of biocompatibility is there. But I soon discovered that 1 in 10 of those children will have croup-like symptoms afterwards, and they may have it along with stridor for a good few days, and 2 or 3 are memorable. One of them ended up with a seroma. And when I looked into the literature, I usually say to myself, these materials have been used, or that suture have been used, or that instrument have been used in other specialties. Let's see what others have found. And you can see in the cosmetic literature how hyaluronic acid can cause seromas and reactions in tissues, facial tissues, and other places where it gets used. Now, my colleagues who use other material, including hydroxyapatite, say that they do not encounter that problem. So the advantage remains in terms of speed and simplicity, but the problem of injection is that it's imprecise. You don't know exactly where and how much. It's not like a pocket of space that will retain it and you'll pump it up. It's not like your car tire. It can go in different areas. And the 1 in 10 problem that I've just mentioned. The evolution of any single surgeon and the evolution of the specialty, I think, have impacted our approach and our attitude towards repair. Repair in the olden times was done in the absence of enough choice of intravenous agents of anesthesia. So people used inhalational anesthesia or situations or conditions where there is no spontaneous respiration, and that lengthened the procedure. The instruments were definitely less precise at the time. Many of those children ended up in intensive care and intubated. We all forget that the end of the 80s and the 90s have seen the introduction of intravenous agents and flexible and even rigid scopes that are way more precise than that. The next hurdle is really about technique. And I was not really, I was properly trained in 6 Children's Hospital, but we didn't do repairs over there at the time, and the interest in swallowing had not caught up. So I self-taught, and I learned about ergonomics. I learned about which suture is going to be easier for me to use, slippery versus non-slippery, wetting my instruments, wetting the larynx that's going to dry up during your procedure. My first one took about maybe a couple of hours until I took 2 or 3 sutures. Now it's 20 minutes, and 70% of my children go home on the same day, and 0 end up intubated, unless obviously we're talking about a larger cleft or a deeper cleft. So I tell the parents, look, if I inject, you're going to come back again. And across the board, it's 50 to 60% response rate, 50% of them temporary, and the rest permanent. Whereas all the evidence is confirming somewhere between 75 to 85% good success with repairs. Do some of them break? 100%, but we don't know how many. We don't know which technique. Cincinnati has produced a first article demonstrating that laser techniques are less favorable, and a good difference. The breakdown, however, of the repairs and the resolution of the injections have been a silver lining, in my opinion, because they have demonstrated to the skeptics with a practical N of 1 study or crossover study that they work, because the symptoms relapse after an initial good response. So that is quite, a serendipitous kind of indication that we are on the right track.
In terms of sutures, what sutures do you like to use? And then in terms of ergonomics, what have you found to be helpful in terms of, whether it's bed height, the chair, how you sit?
So I use the PDS, and I, generally speaking, in the typical age, I use a 7.0. The ergonomics really go back to even, and that's probably a reflection of age and and time at work in general. I pay attention such that I go back to my years when I learned microsurgery. You always have to sit with all your joints at right angle, pretty comfortable, elbow support. I wrap around the head and the laryngoscope a simple white sheet, so that I can see the suture and it doesn't mix up with the hair of the patient. I could see it easily. I remind the surgeon in training that they're going to be working at 2 focal lengths, one under the microscope and the other one when they come outside and they have to do their throws. And you have to have somebody who's holding one end of the suture while you're using the pusher to go down on the, all the way down the 40 centimeter focal length. So these are some, and as I mentioned, I find that with the duration of the procedure, even just for 10 minutes, you find that the larynx dries up from the intensity of the light. So I wet it quite often with saline. All my instruments are wet and all my sutures are wet. I inject a little bit of obviously lignocaine with adrenaline in that site, and I just no more than zero 0.2 cc's. All of these little things make a difference. The hold of the suture of the needle itself should not be classical at right angle, especially in the first suture. You actually hold it like a harpoon, and you reverse it as a reverse harpoon, as I call it. And these are all the products of trial and error and a little bit of thinking.
And then for your technique, do you use laser or to open the mucosa, or do you use a cold technique?
It's purely cold technique.
With like laryngeal scissors, or how do you open up the mucosa?
Yeah, it's I try to start with a sickle knife, but with one hand exerting traction posteriorly, and usually the left leaning, left curving scissors. I incise the mucosa in between the arytenoids, and then I go slightly on the mound of the arytenoid without going into the cartilage. And I take 4 sutures nearly every time.
And then what is part of your postoperative management? Are these patients on PPIs? Do you send them home with a steroid taper or a modified diet or anything like that?
The diet depends on the result of the fees, and it doesn't get changed immediately. The postoperatively, if they are on PPIs, they will continue on PPIs. I make sure that if the child has had pneumonias and wheezing, that they basically have been, let's call it, cleaned enough. Some bronchodilators and inhaled steroids are given beforehand, and they continue afterwards, and that varies. That gets individualized. If they have not been on PPIs before, I only give them 2 weeks worth of it. This is a tiny wound at the end of the day. You know, your tonsillectomy heals completely after 2 weeks. That will probably heal in a handful of days. I don't really give a whole host of instructions to the parents. What you see is what you get in the immediate post-operative period. And I never really repeat the assessment before 8 to 10 weeks. I used to try and kind of, be over optimistic, and I think most surgeons actually have confirmed that.
So at 8 to 10 weeks, they come back and see you. What happens in your clinic? How do you assess them? And what's a good outcome? And what outcomes are you looking at? What are the metrics?
Good question. I basically have, I tell the guys that, in training, that I'm autistic about how I assess and how I do it back again. So I have a drill of questions. It's a smart phrase that I put in our electronic medical record system. And there is an equivalent ask for all when they come back, in addition to asking whether they have had problems afterwards, including pain, readmission, and so forth. And so we basically go and say, okay, how do you feel right now? If the child is still on modified diet, then we really need to thin that during the examination and repeat the fees or the modified barium swallow. And if the child is on non-modified diet, sometimes the parents would come and say the choking has gone down and so forth. I would caution, I always went along with, or initially I went along with what the parents have seen, because at the end of the day, you don't treat a test, you treat the child. But I must admit that the resolution sometimes of the symptoms precedes the resolution of the instrumental assessment. And one has to be, skeptic also about the placebo effect. Parents are always hopeful that something is going to happen, child is going to be better. It also depends on the season. You might be doing it in the summer or the spring, and the winter is gone, the number of infections are less. By the same token, they might have been ill because you've done it in the beginning of the fall, and they have siblings and they've had a few colds, and there is an interpretation that it's a doom and gloom. So 8 to 10 weeks, I'll say that, and again, I need to remeasure that. It's probably, you see a response related to your surgery directly within the first 6 months in most of your successful patients. You get rid of the thickening, or you thin it even more, or you work towards a thinner consistency, water type of consistency. The question that you pose is also very important. If I have a neurologically affected child, and I'm very precise about what's a neurologically affected child, because there are neurologically affected children that their neurological problem doesn't have anything to do with dysphagia. There's no need for lumping that. But you want, as much as possible, an oral component to those children. You need to start working it so that the plasticity of the brain doesn't actually get lost in terms of swallowing function.
And then as we're starting to round it out, and as we come to an end, I'm excited because we got to do a thorough conversation on type 1 laryngeal clefts. In a few, how do you, can you tell us a little bit about nuances or considerations really for some of the more advanced laryngeal clefts, whether it's type 2 or 3?
I definitely will tell you that my experience doesn't encompass many of those.
Thank God that most of us may not see this, but every few years, hopefully, if ever,
They usually will come with an additional problem. And that additional problem will have something to do with the swallowing. And I tell the parents, I can basically shut with a few procedures. And I tell them always it's going to be a few procedures, because this cleft is telling you, I don't have enough tissue with nerve and blood supply over here. Otherwise, I wouldn't be a cleft. So you need to go follow the classic instructions technically in terms of getting the apex, protecting the airway to the best of your ability. There are people who will do the type 2 and 3 without a tracheostomy. I certainly have done tracheostomy in both type 2s or the 3 type 2s that I have done before, and I did it transiently, and it made life a lot easier during the procedure. And I sleep well, and the patient sleeps well. It may delay the decannulation to some extent, but again, they're apples and oranges. 3s are going to be a battle, and the pearls that I have heard from Dr. Mike Rutter and Dr. Reza Rahbar have always been, you're going to be friends with these patients for a long time. And whereas you're talking to a type 1 and a type 2 about normalization and progression of swallowing and preservation of that skill, you're talking to 3s and 4s about preservation of life, which is a very different primary objective. And the remainder is a very, very, very long haul, and you need to drill it again and again. It's one of those that we classify as difficult conversations.
Well, thank you so much, Hamdy. I learned a ton. As we wrap it up, any final pearls that you want to leave our listeners with?
I think the piece is that my experience with how the parents feel like. Those are not trivial problems, and the lack of knowledge in the community, the lay community and ours, is a first battle for all of us. We did a project with a master's student, the involvement of a master's student, and we put together a parent-reported outcome questionnaire for otherwise healthy children so that we can screen, or alternatively, on occasions, do without some of the instrumentals with their costly and time-consuming nature. And part of that was a qualitative assessment. So our first 6 to 7 parents came out with a phenomenal, point. We were basically ignored, or we were accused of seeing things. We were told it's partly in your head, or at least, if not wholly in your head. 2 of them had suicidal ideation. And I was quite privileged to get interviewed by a BBC food program, actually at a little bit of my instigation, because they talked about dysphagia in adults and I wanted them to talk about dysphagia in children. And a patient who was managed and being managed as we speak in Britain, his mother corroborated this. She said, I was told, you need to see somebody for your mental health. This child has no problem. And this child continues to have an alternate route of feeding up till this time. And only just over a year ago did this child have even a G-tube. So most of the life of this child has been spent with an esogastric tube, with what you can imagine in terms of the difficulties. So this is a basic function. It's one of the most promising that our specialty will tackle, along with others. This is a fantastic example of people working together and seeing the fruit of their work. And it is so appreciated by the parents. You have no idea. It may sound to start with like an airy-fairy situation, and it's healthy always to approach it with a degree of skepticism, but the impact is profound.
Thank you so much, Hamdy. If any of our listeners have any questions for you, are you on any social media? And if not, they can reach out to us through BackTable, and we can relay the message as well.
Absolutely. I'm on Twitter, otherwise known now as the X, and more than happy to answer questions through yourself or through my email at the University of Alberta as well.
Awesome. Thank you so much. I learned a ton. I think it's a wrap.
Thank you. Thank you so much, Gopi. It's been an honor.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend. If you have any questions or comments, direct message us at _BackTable ENT on Instagram, LinkedIn, or Twitter. BackTable ENT is hosted by Gopi Shah
and Ashley Agan.
Our audio team is led by Kieran Gannon, with support from
Josh McWhirter,
Aaron Bowles, Nick Shellcross,
Josh Spencer.
Design and digital marketing led by Brian Schmitz, with support from
Taylor Spurgeon Hess.
Social media and PR by Chi Ding.
Administrative support provided by Jamila Kennebrew.
Thanks again for listening, and see you next week.